Bismillahirrahmanirrahim. Assalamu alaikum. Today we are going to discuss a very important topic in gynecology, that is about the ovarian cysts. And today specifically we are going to discuss about the benign ovarian cysts. Ovarian cysts counts for a large number of gynecological OPDs. Like we will come across, I don't know, so that even a single day will pass by in a month in a gynae OPD where we don't come across a lady with an ovarian cyst. So therefore, to have a general overview and a specific orientation regarding the ovarian cyst and the ovarian structure, and thus to have a correct diagnosis and management is very, very important. Clinically, this subject is very important as well as regarding your exams. Like it is part of your UHS, what we make the standards for the examination, that it is mandatory that you are going to get some questions when you are discussing about the gynecological neoplasm, benign or malignant. Then the ovarian cysts, they are one of the most important subjects which are discussed in the exams as well. And as well as the clinical overview is very important because you come across your daily life these cases. So I hope inshallah today we will be having a knowledge about it. So about the normal ovaries, the normal size can be around 5 into 2 to 3 centimeters. It is not hard and fast rule because variation in the dimensions can result from endogenous hormone production, which varies with the age and the menstrual cycle, as well as exogenous substances which are used, including the oral contraceptive pills, GnRH agonists, which can be the part of regime of fertility management, and other gynecological diseases like endometriosis are part of the management of the large fibroids as well. So, and the ovulation and induction medication, which is used in the management of fertility, which we discussed in one of our lectures on fertility, rate resulted ovarian hypercytoinduction stimulation and resulted in the increase in the volume of the ovaries. We will see some of the pictures later in the lecture as well. So, what we want to emphasize is that the more the ovaries, their size, their functions, it is not always at all the times and at all parts of the age and the cycle of the women. They are not in a constant phase. They are affected by the endogenous as well as exogenous factors for their normal functioning as well. And some of the ovarian cysts or other neoplasms can part of their normal ovarian function, and therefore you should have a clear knowledge that where are the domains for a normal thing or a regular thing varies into the abnormality. So you should be able to pick that up. So for that knowledge, the most important thing is that you should be knowing about the structure of the ovary. You should be knowing about the structure of the ovary. Because as you will see further in this lecture, that most of the neoplasms which are arising in the ovary are related, and it would be easy for your memorization and for your concerns also to know that from the following structures they are arising. As you know that in the ovary we have follicles, isn't it? You know that we have follicles. So just keep in mind that related to follicles we have follicular cysts, which we will discuss later in detail as well. Secondly, important thing also remember that this follicles are also highlighted by granular cells. So granular cell also carries a risk of becoming a neoplasm. That's it. Then another important modality in the ovary is the stoma, isn't it? Stoma. So the sex cord stomach tumors are also one of our big parts, which we can discuss about it. Another important thing is the corpus luteum. As we are aware about it, from the normal menstrual cycle, that the corpus luteum is also important structure in the ovary. So this is all the neoplasm related to the corpus luteum. This is also important part of the clinical scenarios which we come across in our daily gynecological OPD. This is very important. Similarly, the germ cells. You see, this is the germinal epithelium. The germinal epithelium. Germinal epithelium is also can be later they get develop into some nuclei. These are the structures like the follicles, the granular cells, the stroma, the corpus luteum. These due to some variation in their function can result in the relation of formation of cysts. Similarly, thicker cells are also can be involved in the formation of neoplasm in the ovary. So the lifetime risk of ovarian neoplasm is a woman has 5 to 10% lifetime risk of undergoing surgery for a cystic ovarian neoplasm. And among these 5 to 10 time risk of undergoing surgery or risk of having a neoplasm, 19 to 21% of these will be found in the ovarian. So here an important thing which I would like to discuss with you is that whenever we are considering about ovarian neoplasm or
So, as we were discussing that the important thing about differential diagnosis of the adnexal masses. Adnexa means ovaries. So, which is in the pelvic side wall, and the most important structure in the pelvic side wall is the ovary. So, for the differential diagnosis of the ovarian masses, either the structures in the pelvis which are involved, like ovary, fallopian tubes, and uterus, we are going to discuss, and the pathologies which can mimic the adnexal masses, and similarly in the abdomen, the bowel. So, for the ovary, the cysts can be which are cystic in structure. They can be functional cyst, neoplastic cyst, like benign and malignant one, and the endometriosis, which you have discussed already in detail in the previous lectures. And the solid counterparts can also be the neoplasm. Neoplasms can be benign or the malignant variant as well. And the fallopian tubes, that there can be tubo-ovarian abscess. This we are going to discuss further in your lecture. I think this you discussed already also about the pelvic inflammatory disease, which can result in hydrosalpinx. And these can also have a differential diagnosis regarding the ovarian neoplasms. Similarly, tubo-ovarian abscesses can be solid as well. An important differential diagnosis can be ectopic pregnancy, and which can be easily ruled out by doing a urine pregnancy test. Para-ovarian cysts, which are congenital, or they are the remnants of the congenital structures. Neoplasms can be there as well of the same structures. In the uterus, there can be an intrauterine pregnancy in a bicornuate uterus. There can be pedunculated or intraligamentous myomas as well. As considering the abdominal part, There can be sigmoid or cecum distended with gas or feces, which can present with pain or a feeling of mass. There can be diverticulitis, ileitis, appendicitis, and colonic cancer. Appendicitis being one of the most common uh, entity among the differential diagnosis of an ovarian mass. Uh, Miscellaneous can be distended bladder, pelvic kidney, and abdominal wall hemangioma in cases of surgeries. So, what is the differential diagnosis of the adnexal mass? It varies considerably with the age of the patient as well. So, while considering a differential diagnosis, the age of the patient should also be kept in mind. In the premenarcheal girls and postmenopausal women, adnexal masses should be considered highly abnormal. This is very important because in a premenarcheal girl, which we expect is that the size of a ovary should be very small. Why we should be feeling a mass of it, or why should it be increased in size, either on ultrasound or on a clinical features. Similarly, in the postmenopausal women also they are now becoming atretic. So why is it the size increasing? Then it carries a suspicion for us. In menstruating patients, differential diagnosis also varied. Now, for the diagnostic evaluation of the patient with an adnexal mass, you need to have a complete physical examination, pelvic ultrasound, CT if it is required, colonoscopy or barium enemas if the high suspicion of involvement of the bowel, and if laparoscopy or laparotomy in cases where you want to have a diagnostic or a therapeutic encounter together. So, regarding the ovarian masses, now this is the a very broad classification for it, that either they can be ovarian masses can be functional, they can be inflammatory, neoplastic, and the other variants. So, for the functional cases, there can be follicular cyst. As I told you, there are follicles in the ovary, so it can form an ovarian cyst. There can be cyst in the corpus luteum, which is called as luteal cyst. These are the important variants, or a theca lutein cyst, or a theca lutein cyst. So, therefore, in the previous slide, I showed you the structure of the ovary, because when you keep the structure of the ovary in your mind, then you are not going to forget the different variants which are coming as the cysts, because the follicle, the corpus luteum, and the theca cells, they are present in the ovary, and these can be um, have some abnormal change which can lead to formation of cyst in these structures. Among the inflammatory variants, there can be a tubo-ovarian abscess, which is resulting from the PID, pelvic inflammatory disease. The neoplastic variants can be benign, borderline, or malignant. Like these cysts can be benign, borderline, or malignant. The other variants are endometriomas, enlarged polycystic ovaries, and para-ovarian cysts. So the common ovarian tumors are either they are functional cysts in the infancy, can be. There can be functional cysts in the infancy as well, prepubertal or adolescent age, in the reproductive age. But when we are very less likely to consider a functional cyst in perimenopausal or postmenopausal age. Therefore, I told you earlier that the variation of the cyst regarding, or evaluation of the cyst of an ovarian cyst, keeping in view the age group, is very important. Like whenever we consider of a small cyst, like of an ovarian cyst of 3 to 4 centimeter or 2 centimeter, the more common variant which will come in our mind would be of a functional cyst. But as we approach in the perimenopausal, in the postmenopausal age group, if a lady presents to us with this problem, then we are going to consider more of the epithelial ovarian tumor or the neoplastic ovarian tumors, as we don't expect the ovaries to increase in size in this age group, as they have lost their production and their responses to the gonadotrophins. Similarly, in the infancy or the pubertal or adolescent age group, germ cell tumors can be common. In the productive age group, dermoid, it is common, and in the perimenopausal or the postmenopausal, it will be less likely to consider them. Now, for the functional ovarian cysts, The functional ovarian cyst, the different variants of the functional ovarian cyst, as in you mentioned in the textbooks, are also follicular cysts, corpus luteum cyst, and the thecal lutein cyst. Luteomas of the pregnancy can be present, which are due to the increased production of beta HCG. By far the most common clinically detectable enlargements of the ovary in the reproductive years. So in the reproductive years, the functional ovarian cyst, which can arise from the follicle, corpus luteum, or the thecal lutein cyst, are the most common clinically detectable enlargements. They are all benign, usually asymptomatic, can present with a mild pain, and mostly managed conservatively. So, the follicular cyst. Cystic follicle is defined as follicular cyst of a diameter more than 3 centimeter, because up till 2 to 2.5 centimeter, a follicle is a normal follicle. A ripened follicle or mature follicle can attain a size about 2 to 2.5 centimeter. If the size increases more than 3 centimeter, then we are going to label the follicle as follicular cyst. Before it, it can be a mature follicle. And the most common functional cysts are the follicular cysts. So rarely they are larger than 8 centimeter, lined by the granulosa cells. As I showed you before, that the follicle is lined by granulosa cells. So definitely the follicular cyst will also be lined by the granulosa cells. Found incidentally on the pelvic examination, and they usually resolve within 4 to 8 weeks with expectant management. So what is it that if a lady comes to you with the mild signs and symptoms, you make your confirmation or diagnosis on your pelvic ultrasound scan, and then what you are going to advise, this is the thing you are going to advise, that you can give her some symptomatic relief for her pain, and then advice for the reassurance, plus expectant management, even and to repeat the scan after 6 weeks or so. And by that time, most of the time, they are resolved. This is the thing we are how going to deal with the follicular cysts. May rupture or torts occasionally, causing pain and peritoneal symptoms. Very less likely it happens. So you see, these are the pictures how it can present. This is the uterus in a pelvic scan, and this is the cyst how it presents to you. Okay. Then come the corpus luteal cysts. This is less common than follicular cyst. May rupture leading to hemoperitoneum. In these cysts, the corpus luteum cyst, there is more risk of rupture. Although I would not say that all of them rupture, more risk of rupture than the follicular cyst, and because they are already bleeding inside those, there can be a risk after the rupture of hemoperitoneum and requiring surgical management more in patients taking the risk is more, it's not proven, but that with who are taking anticoagulants or with bleeding diastasis. Unruptured cyst may cause pain because of bleeding into the enclosed ovarian cyst cavity. So unruptured may cause, because if it's going to bleed inside, they can cause pain. So what we are going to see on the ultrasound, you see, we can have this, that is known as a fishnet appearance. This is like a fishnet appearance, and the hemorrhagic cyst can on uh, uh, naked eye examination, after if it is removal, it can be seen like this. So this, you see, this was a hemorrhagic cyst, which is showing hemorrhage inside the cyst wall. Its appearance is like this, as compared to the follicular cyst, where you saw the fluid was clear. You see, this fluid was clear, and in comparison to that, in a hemorrhagic cyst, the fluid was showing some ground glass appearance, or we can say fishnet appearance as well. So it's not clear one because there is hemorrhage inside it. You can see in both pictures like this. Then come the thecal lutein cysts. These are least common, usually bilateral, result from overstimulation of the ovary by beta HCG. And you are going to tell me when the overstimulation of the ovary happens by beta HCG. Yes, it can happen in cases of molar pregnancy. I know you have discussed this before, where you can encounter thecal lutein cysts. You can also encounter in cases of multiple pregnancy, where beta HCG levels are more because of the increased size of placental tissue. You can have beta HCG stimulation in cases where you are giving management for um, subfertility with ovulation induction, and in those cases also we can come across them. So you see, Uh, Normally, they don't occur in a normal pregnancy, can be associated with hereditary form moles with multiple gestation, use of ovulation induction. So they may be quite large, multicystic, and but they regress spontaneously as the pregnancy advances. You see, these are the thecal lutein cysts. You see now the picture, how the big, small cysts they look like, and on the naked eye examination they look like this. So, like an ovarian hyperstimulation as well can manifest like this. So, for the management of functional cyst, as I told you before, it is expectant management. Watchful waiting for 2 or 3 cycles is appropriate. Combined oral contraceptive pills, which is a belief. This you will also come across. Therefore, we have mentioned it. It is a. It was previously it was used in a much number of patients that they used to give oral contraceptive pills, keeping in view that maybe they would suppress the gonadotrophins and the ovary will result come to their appropriate site, but it are of no use. And should the persist, maybe surgical intervention can be required. So now coming across to endometriomas, as the name indicates, this is the modality which we can come across in ladies with endometriosis. And as we know that most common involvement of endometriosis is the ovary, and where it can result in the formation of endometrioma. Endometriomas are the pseudocysts formed by invagination of the ovarian cortex, sealed off by adhesions. They may completely replace the normal ovarian tissue. Cyst walls are usually thick and fibrotic, and the ultrasound scan shows anechoic cysts to cysts with diffuse low-level echoes to solid appearing masses. Fluid or debris fluid levels may also be seen. They may be unilocular or multilocular with thin or thick septations, and malignant transformation can be seen. You see, this is known as ground glass appearance. This is known as ground glass appearance. So ground glass appearance on an ultrasound scan was pathognomic, not confirmatory, but most of the time it points towards the endometriosis. As you saw before, for the clear cyst, how the ultrasound picture was, for the hemorrhagic cyst, how it was, and in cases of endometriosis, this is known as ground glass appearance. And this is how in the naked eye scan you can see. Now, coming to the benign ovarian tumors, those were the functional cysts, and now we are coming across the benign ovarian tumors. While considering this also comes in our mind, as I told you before, that we come across that the epithelium, what were the structural formation, what is the microscopic or what is the histological variance involved in the formation of a normal ovary, and their variation can lead to tumors. So this is a very simple rule to follow and principles to follow to remember the ovarian tumors, that what was the normal histological constituents of an ovary can result in the formation of cyst as well. So, regarding the histology, there is serous epithelium, mucinous, there is germ cell. If, just catch with me at this time. Fibroma, there is stromal tissue, thecoma, theca cells, renal tumor. So let's see. If the serous epithelium is present, it can result in serous cyst adenoma. Mucinous cyst adenomas, dermoid cyst. Dermoid cyst is the tumor of germ cell tumor. It is a germ cell tumor, and which can result in dermoid cyst, as we will discuss later. And it is one of the most important benign ovarian tumors, and a very important question regarding your exams as well. So, and then comes fibroma, and we are going to discuss all of them one by one in detail. For the serous cyst adenoma, these are generally benign, bilateral only 10% of the cases. Risk of malignancy is around only 5 to 10%. And what is the gross appearance? They are multilocular with papillary components, often on, not in all the cases. Semoma bodies can be present histologically, and they are associated with fibrosis and may lead to cyst adenofibroma. So they are serous cyst adenoma. So as the name indicates, most of the serous fluid will be present in them. You can see this is how they can present the serous cyst adenomas with the big masses, but with the clear cystic fluid. With a clear cystic fluid. If we opened it, it is the picture was like this. See, the cyst wall, it is cystic, and there is a clear fluid. You can see in this picture as well. There is septation and the clear fluid. The mucinous cyst adenoma, as the name indicates, they have mucin in there, or mucinous substance in there, uh, as a part of their neoplastic tissue. They have tendency to become huge masses, round ovoid masses with smooth capsule that are usually translucent or bluish to whitish gray. Why? Because they are having mucin, not the clear cystic fluid inside them. Interior is divided by discrete septation into loculi containing clear viscid fluid. Clear or viscid fluid. So I also remember it with, oh, it is mucinous, so multiple septation, M and M. So there is septations. Epithelium is tall, pale staining, secretory with basal nuclei and goblet cells. As we go for the histology, 5 to 10% can be malignant. As you see in these pictures, you see, this is the histology. This is how the epithelium. This is multiple septation. You can see in the cyst wall. This is a multiple septation and large. Now you see, this is the picture. This is how these are the multiple septations. You can see it is quite different from the serous cyst adenoma, the mucinous cyst adenoma. Now, then coming to dermoid cyst. Dermoid cyst is originating from the germ cell. It is coming from the germ cell tumor. And important thing about it is it is often bilateral. It has thick, opaque, whitish wall, contains hair, bone, cartilage, and a large amount of greasy, sebaceous material. Now, considering its contents, what comes into your mind? It means that it has the variants from the three germ layers. So it's a germ cell tumor. Now you will not forget dermoid cyst. If you consider its contents, there can be hair, bone, cartilage, and large greasy sebaceous material. So as these are the variants from the three germ layers, mesenchyme giving bone or cartilage, and the outer part giving the formation for hair, and endoderm also there. So endoderm, mesoderm, ectoderm, as we know about the germ cell, therefore it can be part of the variant of a germ cell tumors. And you see, microscopically, all the three germ layers, ectoderm, mesoderm, and endoderm, can present with their variants in a dermoid cyst. Malignant change is rare, in case it's only 1 to 3%, usually of a squamous type. Now, what is the important complication which can happen dermoid cyst, which is more likely in cases of dermoid cyst? What do you think by these materials? These materials make it a bit heavier, isn't it? So when things become heavy, there is a more risk of its torsion, of its twisting upon its pedicle. So what is torsion? It is a twisting of the tissue on its pedicle. And when a twist occurs, what will happen? There will be occlusion of the blood supply. Very good. So there would be risk of pain, gangrene, a necrosis of the vascular tissue. So these are the risk of torsion in any part of the body if it happens for any structure. So same is the case for the ovarian tissue. And ovarian cystectomy is almost always possible, even if it appears that only a small amount of ovarian tissue remains. Now, what I want to tell you from this part is that when we go for the surgical approach, the patient presents to us in acute stage. She is not resolving with the conservative management. The mass is of bigger size, like 8 to 10 centimeter, with ultrasound confirmation of the dermoid cyst. Then what we do, we are going to do surgically. We are going to do surgical removal, not of the ovary, not doing oophorectomy, but is the ovarian cystectomy which we are going to do, trying to conserve as much of the ovarian tissue as possible. This should be our approach. Conservative approach should be adopted for this. You see, this is a ovarian dermoid cyst. You see the hair, the sebaceous material like this. So this is how an ovarian cyst can be. A cheesy sebaceous material can be cyst because they have variants of the three germ layers in it. Now, what is this ultrasound picture telling us? This arrow is showing, this is pointing towards some shiny structure, and this is the teeth. This is the teeth which is appearing in the ultrasound scan as the shiny structure. So this can also be present in a dermoid cyst. Now, the next of our plastic tissue is fibroma. It is the most common benign solid neoplasm of the ovary. Now, the previous one we were discussing about the cyst and the cystic and the mucinous cyst adenomas. They had serous or mucinous contents inside the cyst wall, but the fibroma, it is the solid structure. As we discussed before about the major classification, the fibroma is one of the benign solid neoplasm of the ovary, and can come from the stromal tissue. It is originating from the stromal tissue of the ovary. It comprises about 5% of the benign ovarian neoplasm and 20% of all solid tumors of the ovary, frequently seen in the middle-aged women. So fibromas are not common, I would say, like in a very younger age group. They are common, but rather in a middle-aged group women, characterized by their firmness and resemblance to myomas because they are solid. They are coming from the stromal tissue. So, misdiagnosed as exophytic fibroids or primary ovarian malignancy, they can be misdiagnosed by it. They are not hormonally active. Fibromas may be associated with another complication which can happen in fibroma. As we discussed previously with dermoid cyst, the important complication can happen is torsion. Torsion can lead to avascular necrosis and gangrene of the ovary until unless we take action, timely action for the management of dermoid. Similarly, for the fibromas, and other important clinical entity can be, which is also important regarding your exams as well, can be associated with ascites or hydrothorax as a result of increased capillary permeability thought to be a result of vasectomy derived epithelial growth factor. So a fibroma can coexist with an ascites, which is it means fluid inside the abdominal cavity, and hydrothorax meaning fluid inside the chest cavity, plus the fibroma. So three clinical things like fibroma, ascites, and hydrothorax, if they come together, it is uncommon, but it can result in a condition known as Meeks syndrome, which is ovarian fibromas, ascites, and hydrothorax. Their triad is known as Meeks syndrome, but it's uncommon, and it usually resolve after surgical excision. Like if you do the surgical excision of the fibromas, the hydrothorax and the ascites will resolve by themselves. This is how they can present. You see, their appearance looks solid. Their appearance looks solid. This is how they look like. Now coming to thecoma. These are the solid fibromatous lesions that show varying degrees of yellow or orange discoloration. Theca, as the name indicates, almost always confined to one ovary. Usually more than 40 years of age it can present. 65% are after menopause, may be hormonally active and hence associated with estrogenic or occasionally androgenic effects. Luteinized thecomas, when the lutein production is more for them, they are in younger sclerosing peritonitis and ascites. Lighting cell thecomas can also be present. They are rarely malignant. Then comes the Brenner tumor. Uncommon tumor, grossly identical to fibroma. So grossly, if you look with the naked eye, it looks similar to fibroma. It means it has a solid on appearance. Arises from the vulvar cell rest, also from the surface epithelium and ovarian stroma. On microscopy, we can see markedly hyperplastic fibromatous matrix interspersed with nest of epithelioid cells showing coffee bean pattern. So what we see on microscopy is hyperplastic fibromatous matrix, hyperplastic fibromatous matrix and epithelioid cells, considered uniformly benign. So we consider them as benign, but scattered reports of malignant Brenner variables can be seen. Endocrinologically inert, but can be associated with virilization endometrial hyperplasia. You see, they do look like a bit fibromas, their gross appearance, until unless proved otherwise by histology. Now, then come the gonadoblastomas. Now, what by the word of gonadoblastoma, what does come in your mind? By the word gonadoblastoma, gonads, and I think we have discussed this earlier in our very earlier chapters when we started gynae, and I myself took your lectures related to this topic. Do you remember? Just do a bit of brainstorming. Gonadoblastomas, or I would say gonadoblastomas. Yes, you might have now come across with them. You have maybe have guessed well. Gonadобластoma is a rare benign tumor that has the potential for malignant transformation and affects a subset of patients with intersex disorders or disorders of sex development. We discussed these in detail about the hypergonadotrophic hypogonadisms, and there were hypogonadotrophic hypogonadisms where there were we talked about there were XY females where the genitals, yes, internal sex organs were of male variant, but there were problems with the receptors and the manifestations at the enzyme levels, which resulted in phenotypically females, and so on. So these things we discussed in detail in our earlier chapter when we started gynecology in, I think, second or third lecture. And these internal sex organs at that time also I discussed with you in the later life can have a malignant transformation, so they need to be removed. They are, although seem to be dormant in an earlier phase of life, but I would say that rather they are an unnecessary structure which can have a potential of malignant transformation. So, therefore, these gonades which were transitory or which were in a rudimentary state in the early life of a individual of a disorder of sexual development, they were present of internal sex organs, but the phenotypically they were different or they were coexistent of the male and female genitalia. They have the potential of development of and ovarian part. One of them would be the ovarian tissue, which is involved in the internal sexual organs of these types of um, individuals, and these have the potential for transforming into malignant counterpart. So both germ cells and sex cord stromal cells are present in these types of gonades. They arise in patients with cisgenetic gonades. You remember, like 46XY and 46XY mosaics. So they can present usually as phenotypical female. This I discussed with you, and at less than 30 years of age with primary amenorrhea and virilization. So there were androgen insensitivity syndrome and enzyme deficiency, and all these we discussed in detail. So in all these individuals, if you have just a quick look previous at your previous lectures, you will come across on your book also in the second or third chapters in your textbooks that these gonads have the potential to undergo malignancy in any part of their life. So their treatment is laparoscopic or laparotomic removal of the bilateral dysgenetic gonads. So further treatment depends upon the malignant germ cell component. Now, again, this is just was the overview about the classification. The most important thing which we should come across, which we should study, is the clinical presentation, which we should not forget for any of the ovarian cyst if a lady presents to you, because you are going to be clinical doctors, inshallah. So the clinical presentation and just reaching your diagnosis after the clinical presentation of the patient come across to you is very important. So I would emphasize on the clinical aspect more and more for you. For the asymptomatic patient accidentally discovered on ultrasonography, it can be a clinical presentation. Patient came for other routine evaluation, and incidental finding was on a pelvic scan of a cyst. There can be a chronic pattern of pain, increasing abdominal girth or over months or weeks in case of benign tumors. Associated with secondary symptoms can be of anorexia, nausea and vomiting, and urinary frequency because of the close proximity of the ovarian structures to the bowel and the urinary bladder. Could be associated with primary or secondary amenorrhea, menstrual irregularities, virilization, and precocious puberty, depending upon the part of the histological variant of the ovary which is involved in the development of the uh, neoplasm, as I discussed in your second slide about the normal histology of the ovary. This is very important to to keep in your mind. They can become acutely asymptomatic if undergoes torsion, as in case of dermoid cyst, or a rupture of hemorrhage, as in case of a corpus luteum. Benign ovarian neoplasm are indistinguishable clinically from malignant counterparts, but not in all the cases. If there is no history of weight loss, if there is no history of anorexia, if there is no history, family history of any ovarian tumors, and the size is of bit lesser, like less than 5 centimeter or 6 centimeter, the ultrasound comes with the other modality. So in the history, although it will not be confirmatory for you, but they can give you clues about the benign nature as well. So what are the complications which can happen in the benign ovarian tumor? This is torsion, as in case of dermoid cyst, which is a mature cystic teratoma, mature germ cell tumor, intracystic hemorrhage, as in case of corpus luteum cysts, infection, like in case of tubovarian abscess, rupture of the cyst can occur, pseudomyxoma peritoni. This is an important complication, although benign, which can happen in cases of mucinous cyst adenomas. It can happen in cases of mucinous cyst adenomas if that cyst happens to rupture. If a mucinous cyst happens to rupture, what happens is that the mucinous material inside the cyst, it gets spilled over inside the abdominal cavity, mating matching the bowel loops together, and this can lead to this pseudomyxoma peritoni. Okay, pseudo means because it is not coming from the any pathology of the abdominal structure, it is coming from the ovarian uh, variant of the neoplasm, therefore it is known as pseudo. And what is the myxoma and peritoni? It will cause peritonitis, a sort of peritonitis, because the bowel loops will get adherent to each other, matted to each other. Therefore, its name is peritoni, but it is pseudo because it is not of the abdominal origin or the peritoneal origin, but rather coming from the ovary by the rupture of the mucinous cyst, and that mucinous material, when spilled across the abdominal contents, it can lead to pseudomyxoma peritoni or the malignancy. Can happen. So, how is the management then carried out? A complete physical examination should be done. Abdominal and vaginal examination, not in case of an not sexually active lady, and the presence or absence of any local lymphadenopathy, as we will discuss later in our lectures with malignant counterparts, where lymphadenopathy of especially of pelvic region is very important in cases of evaluation. An important effect which we can see also on clinical examination is when we do a clinical abdominal examination of a larger size of variances, either it is a cystic mass or a solid mass. If it is cystic, it is pointing more towards a benign condition, mobile or fixed mobility. It is also in favor of a benign condition, as in case of masses of other parts in the other parts of the body also. These features are helpful, or these features are reassuring for us to some extent to the leading towards a benign condition. Smooth was irregular, presence of ascites or not, any nodules which are felt, or rapid growth rate. So these are the clinical points which are giving us clue towards its benign nature. This is very important, which we should be always knowing it. Now, then what about the transvaginal scan? In case of sexually active women, we can carry it out. They can give us a pattern recognition, and it is superior to all other scores. As we saw the previous pictures also, like I showed you about the ground glass appearance, the net fish appearance, and the clear cystic fluid, they were more visible and with a good accuracy with the transvaginal scan. So subjective evaluation of the ovarian masses based on the pattern recognition can be achieved with the good sensitivity and specificity with the transvaginal scan. Doppler does not seem to be of much help in cases of benign conditions, but they would be certainly help for malignant conditions, as we will see later in the next chapters. So this is the ultrasound modalities which can scan, which can help us. Similarly, the morphology is also important. You see, the clear cystic fluid more points towards a benign condition, like this is the ground glass appearance, septations. So these are the different variants as we discussed before. So if there is a vascular pattern found in the Doppler, more it is pointing towards the malignancy. And then imaging modalities can be helpful, CT with MRI, where and ever it is clinically indicated. The tumor markers we will discuss in detail in our this lecture with the malignant ovarian tumors, and but in why I have named them here in the benign tumors is that they would help us in case when we want to rule out, like in a suppose I will give you a case scenario, like a 45 years old or a 50 years old lady comes to you with a pain abdomen, and you carried out an ultrasound and found to be having a pelvic mass of around 6 centimeters just, and even and the first suspicion what at this age group what comes in our mind is of epithelial ovarian tumor. Clinically the presentation is equivocal, and at that time I would like to do a tumor marker just to rule out any malignancy. So now what I want to emphasize you that it is not in each and every case of where you suspect malignancy and you want to have a diagnostic or a prognostic value for tumor marker for that case, but in cases of benign tumors, to have the malignancy rule out, just to have a cutoff value or to have to rule out the malignancy, we do carry the value of tumor markers in cases of ovarian tumor, so that we rule out the malignancy. Like the tumor marker value comes out to be in the optimum range in this lady, and thus we are just have a sigh of relief. Okay, we are going to manage you, but the important thing is that the malignancy is ruled out because the tumor marker was in the our required range. So therefore I would want to emphasize that tumor markers in cases of benign tumors do carry an important part of our management, because here we want to rule out our malignancy when we carry out the tumor markers. So this is very important, but we are going to discuss them in detail later. And important one of the tumor marker is CA125 as in case of epithelial ovarian tumor. So it is the tumor marker for epithelial ovarian tumors, and if it comes out to be on the lesser side, less than 35 or 40, so we have a sigh of relief and we consider it as a benign ovarian tumor. So this is very important, which we should have in our mind. So you see, if it comes out to be more than 35 or so, then we are on a we are alert and we want to have more and more evaluation for this patient. So as keeping in view that again I would just quickly want to revise with you that the benign ovarian tumors, always when you want to have a clear knowledge about it, just go across again on the structure of the ovary, the histology of the ovary, and then you are not going to forget the classification and a bit of the differences which we have in those tumors. So again, what were the important ones? These were the epithelial ovarian tumors, the mucinous one, the germ cell tumors, the sex cord stromal tumors, and the thicomas and the fibroma group. So these were the main variants. And for the cystic ovarian tumors, epithelial ovarian tumors, they can be cystic and on the mucinous part. With the cystic, they are of the less bilaterality. Mucins are more bilateral. They have more of the mucin component with them, can result in a complication of pseudomyxoma parischnii. Regarding germ cell tumor, the most important one was the dermoid cyst, which can have a complication of torsion with avascular necrosis of the pedicle. This and the gangrene and can have this complication. We might need to have and as close as possible we should try to go for the conservative management in that part, that if we go for surgery even, we try to save the ovarian tissue. And least but not I would last but not the least would be the fibromas, which are the solid sex cord tumors, but they are, and the stromal tumors, but they are not the malignant ones, and they can result in weak syndrome, one of the rare complications with ascites and hydrothorax and ovarian tumor, and only removal of the tumor will just help the patient out from her misery. So this was only a clearly a layout for you for your benign ovarian tumors. Inshallah, in our next lectures, we are going to discuss about their malignant counterparts and their malignant variants. Inshallah. Thank you very much for your attention, please.